Hello, and welcome to our Foundational Review Concept Map portfolio. We will be explaining the organization of this portfolio. These maps are primarily based off of chapters in our Radomski, Pedretti, and Sames textbooks, as well as the OTPF. The first component that we're going to talk about is one of the domains of the OTPF, which is client factors. And underneath of client factors, you can find body structures, body functions, and values, beliefs, and spirituality, as well as a quick summary of each component. And then on the OTPF is performance patterns, which are habits, routines, and roles. There's also a brief explanation of what each component do. Oh, and I missed rituals. Next, we have performance skills. And the categories underneath performance skills, which are motor skills, process skills, social interaction skills, as well as brief summary of what they mean and what they require the person to do. Our next map is context and environment. We have a brief definition of context and environment, as well as the different contexts that we look into the OTPF, which are cultural, personal, temporal, and virtual. As far as the environment goes, we have the physical and social environment, as well as a brief summary on each one. Last but not least, we have the process and what is involved in the process, which is the evaluation. The category that we do in evaluation is occupational profile and analysis of occupational performance. The next step in the process, we have the intervention and what is required to have in the intervention, which is planning, implementation, and reevaluation. And the last will be the outcomes in the process. And we have summarized those underneath this tab. Occupational performance, prevention, health and wellness, quality of life, participation, role competency, well-being, and occupational justice. Next component on our portfolio is focused on Chapter 5 of our Sames book, which is focused on models and frames of reference in occupational therapy. First, we have defined model and frame of reference. We have the description of the models and four over here. And how models and frame of reference are reflected in our documentation according to top-down approach and bottom-up. Our next map goes into detail on each frame of reference, starting with NDT, following occupational adaptation, occupational behavior, PEOP, PNF, psychoanalytic, rehabilitative, spatiotemporal, and sensory integration. Continuing on frames of reference, we have model of human occupation, or known as MOHO, ecology of human performance, developmental, behavioral, biomechanical, contemporary task-oriented, Canadian model of occupational performance, cognitive disabilities, cognitive behavioral therapy. Lastly, we have frames of reference approaches, which we have top-down approach, which is known as client-centered, bottom-up, which is very biomechanical, and the eclectic approach is just a multiple models or frames of reference that are blended together.
The next component of our portfolio goes into detail on Radomski Chapter 12, which is focused on selection, gradation, analysis, and adaptation. And up here we have included information on selection and gradation. Here we have selection of occupation as end, selection and gradation of occupation as means, and we have different categories of intervention and ways to grade them up or down. And the next component of this map is analysis. And we have information on why OTs analyze activities and the different steps of analysis. Step 1, focused on stating the purpose and identifying task demands. And we have further information on activity-focused analysis, client-focused analysis, environment client-focused analysis. And lastly, we have characteristics of therapeutic occupations and the different components that are necessary. This next map is a continuation of Radomski Chapter 12 focused on grading activities. It goes more into detail on activity-focused analysis. It identifies it, lists the steps that are needed, and we also have included a visual of a chart that has activities that go along with this approach. And next we have performance-focused analysis, and we have the definition here, the steps, and another visual, and procedures for practice from Radomski. And next we have information on adaptation, and we have listed the several reasons that adaptation is required. This next map has parameters that are used to adapt or modify activities, such as the activity demand and the required body functions. And this includes the specific body functions that support the actions that are needed to perform activities and how to adapt them. And we have information on arranging objects relative to each other and how to grade that, and changing the length of a lever arm for adapting activities. And we have here activity demand, required actions and performance skills, and how to adapt activity demands. And we have activity demand, objects and their properties, and how to grade objects and their properties based on size or shape, color contrast, the use of supplemental tools and utensils, weights. Next, I will be discussing Radomski Chapter 13, our concept map focused on learning. Here we have information on the human information processing model of learning, which includes controlled and automatic processing, and implications of the model. We have information on clinical considerations when teaching clients activities. We have information on task-specific skills and transfer of training, and the different levels associated with it. And also the different stages of learning, which are cognitive, associative, and autonomous. Next, we have fundamentals of the teaching learning project, which includes the therapeutic use of feedback, and types of feedback we included were extrinsic and intrinsic, types of feedback schedules that can be used when working with clients, therapeutic use of practice, which includes blocked, random, and part whole, and guidelines for intensity of practice. And we also have the 4 key components of motivational interviewing, as listed right here, and 3 communication styles to be aware, which are guiding, following, and directive. The map I will be discussing is on Pedretti Chapter 7, which is about teaching activities in occupational therapy. And first we have reasons for teaching activities. And information on learning, such as the acquisition, retention, capacities, and types, which include procedural and declarative. And we have principles of teaching and learning in OT, as listed right here. and then more information on structure and feedback of schedules, which includes the types and the environment. And we have information on helping the client develop self-awareness and self-monitoring skills during intervention, which includes metacognition development. And lastly, on this map, we have factors that support the transfer of learning to be aware of.
So concept map number 4 is over evaluation and treatment of visual deficits after brain injury. And this first tab just gives an overview of visual processing within the central nervous system. The second part is about the visual field, and that's the external world that can be seen when a person looks straight ahead. Talks about the deficits, interventions, assessments, and limitations that people experience when they have visual field deficits. The next tab talks about visual attention and scanning, also the intervention, assessments, and the categories of visual attention and how these deficits affect function. So then there is evaluation and treatment of visual deficits following brain injury, and a big one is oculomotor function, and so that breaks down to assessments and intervention when there are deficits in this. There is strabismus, and you can test this as well as observe the patient. The next part is assessing the abilities and capacities in vision and visual processing. So there's a whole screening process for deficits in visual processing. And then more information about oculomotor control. And then optimizing vision and visual processing. And this is some environmental adaptations that can be used, such as large print clock, large print remote, magnifiers, and then there's also sensory substitutions that can be done. And then this last part talks about occlusion, lenses and prisms, vision therapy specifically, and then compensatory strategies, as well as training guidelines for visual attention and visual scanning. And it's important to remember that scanning training is contextual, so it's very specific to the situation that the person is in, and you should always begin it with cancellation task. And that is the end of our concept map presentation number 4 over vision.
Hi, this is Alissa Osgood, and I'm going to be presenting concept map number 5, which is based off of Radomski, Chapter 8 and Chapter 21. So Chapter 8 is titled Assessing Abilities and Capacities, Motor Planning and Performance. And in this concept map, you can see that we begin over here, where we talk about the neurophysiological approaches, and you can see them listed underneath, such as reflex hierarchical model of motor control, then neuromaturational theory, and motor dysfunction caused by CNS lesions. And here's the view of recovery after CNS lesions. The next section is evaluations used by neurophysiological approaches. And you can see below we have the information on that, including muscle tone and associated factors, and assessment of muscle tone over here. The next component that we're looking at is called systems-based task-related approaches. And you can see them below, including systems model of motor control, as you can see here, which includes the ecological approach to perception and action. There's also the dynamical systems theory listed under system model of motor control. And then over here, we're looking at system model of motor behavior and view of recovery after CNS dysfunction. Finally, our last point on this part of the concept map is the evaluation using the systems-based task-related approaches. And you can see the procedures for practice here, as well as assessments of motor behavior and motor function. And we included some graphics from the textbook. Okay, I'm going to continue on with more from Chapter 8 of Radomski. So in this part of it, we We go over assessments of motor behavior and motor function, and you can see those in this area, which includes the arm motor ability test, the Wolf motor function test, the motor activity log, and the very popular Fugel-Meyer motor assessment, which we learned about. Next is assessments of balance, which includes observational analysis, the Berg balance scale, and the functional reach test. We also have assessment of gait. Down here you can see we have reach and manipulation, which we go into the details over in this area. The next important thing that we want to talk about is assessment of praxis. There are different kinds of praxis, including limb apraxia, constructional apraxia, and dressing apraxia. You can see here with constructional apraxia, the Lotka battery is a good assessment to use with this. Okay, moving on. So another area we covered is motor neglect. And you can see that we included the definition. Okay. And that is everything from Radomski Chapter 8. Next, we're moving on to Radomski Chapter 21, which is called Optimizing Motor Planning and Performance in Clients with Neurological Disorders. So first, we want to go up top over here, and we talked about motor characteristics of CNS dysfunction, which you can find to this side of it. Next, we talked about the history of theoretical paradigms associated with rehab interventions to improve motor performance in clients with CNS dysfunction. And you can see those theories here, including Brunstrom's movement therapy, rude and proprioceptive neuromuscular facilitation approaches, and NDT. Next, we have the evolution from impairment-focused interventions to interventions designed to help patients develop effective movement strategies. Over here, we talk about the constraints and affordances. And then we also discuss the important topic of learned non-use and the value of constraint-induced movement therapy. Okay, continuing with Radomski Chapter 21. So there are multiple factors that contribute to optimal motor performance. Here we talk about mechanical requirements for movement execution. Here you see the kinesthetic understanding of foundational movement strategies. Then below we cover various topics, including postural adjustments, the match between task demands and the person's capabilities, awareness of capabilities and expectations of ultimate success, and task analysis, problem solving, and praxis skills. Up here we have the framework for occupational therapy, which has interventions geared toward improving motor performance, and you can see them over in this area. And as we move over here, we see interventions are informed by multiple factors that contribute to optimal motor performance. And here are some of those factors. Also, we have interventions to improve postural alignment and balance, which is very important for people with CNS motor dysfunction. And you can see some of those intervention strategies over here, including ways to improve sitting balance and standing balance. And also we talk about functional mobility, which is moving in bed, moving in the seated position, standing up and sitting down, and just functionally ambulating throughout your environment. Now we're moving to the final part of Radomski, Chapter 21. This part is about occupational therapy contributions to preventing and reducing gait deviations. All right, so we're starting over here with functional ambulation. As you can see, we have this nice picture of the gait cycle with information included underneath it. And then we have information about OT's role in functional ambulation, which is very important. If we move over here, we have interventions to prevent, reduce, and reduce mechanical constraints to upper limb function. As you can see, we have things such as pelvic trunk alignment, mobility, spasticity, and scapular glenohumeral alignment. Over here, we have promoting early movement in the arm and hand through different types of therapy, including mental practice, neurotherapy, bilateral training, kinesiotape. Then we move on to preventing learned non-use, once again, which is very important, and developing effective motor programs for reach and grasp. Finally, we have matching task demands to the person's capabilities. And over here, we can see interventions to improve motor planning in patients with limb apraxia. Okay, and here are some of the evidence for these interventions. And that wraps up concept map number 5. Thank you.
This is Quan Nguyen, and I'm doing concept map number 6 and 7 to complete this e-portfolio. The first part of concept map 6 is optimizing sensory abilities and capacities. So first, these are the parts that you want to consider when choosing an intervention strategy. And then for compensation of impaired or absent protective sensation, there are some compensation techniques that include avoid continuous low pressure damage, avoid concentrated high pressure, and you also want to be aware of extreme heat or cold, avoid repetitive motions and excessive friction, so energy conservation techniques, for example, and you also want to educate the patients on lost sensation to take special care for blisters, cuts, and bruises. With the effectiveness of compensatory techniques, there is a widespread acceptance of these techniques. And then for desensitization, this is chosen when a person has hypersensitivity or allodynia, and it's considered to be relearning to interpret sensory stimuli as non-noxious. And there's 5 levels of techniques. Level 1 includes tuning fork, paraffin, massage. Level 2 includes battery-operated vibrator, deep massage, touch with a pencil eraser. Level 3, electric vibrator, texture identification. Level 4, same but with object identification. And then once you get to 5, it's work and daily activities. These techniques are generally accepted in practice as effective. And with sensory training, the goal is to maintain or restore the cortical hand representation and to regain the use of sensation in the hand. And these are some examples of training and re-education. And then there's also sensory therapeutic techniques after a stroke. So there's passive sensory training and active sensory training, as well as mirror therapy. However, there's insufficient evidence to support their effectiveness. And then moving on to assessing abilities and capacities, sensation. Some evaluation techniques are stereognosis, monofilaments, threshold tests, 2-point discrimination, and some other assessments. And to record the assessment results, there's touch threshold, which uses those Sams-Weinstein monofilaments, static 2-point discrimination, which can be either discriminator or anesthesiometer, moving 2-point discrimination, touch localization, vibration threshold, the modified pickup test, and the quick dash. When interpreting the evaluation findings, you compare the results with those expected based on the patient's diagnosis. And you can use clinical reasoning in choosing the evaluation tools. So you need to observe and see what the patient needs. These are the somatosensory deficit patterns as seen in this picture. And this is what you can expect with an incomplete SCI lesion or with a cortical injury. These are the guidelines in planning assessments for SCI patients. And with peripheral nerve injury, this is what you can expect. As far as severity of sensory loss, recovery of sensation, And then this concept map also includes the neurophysiological foundations of tactile sensation, with some helpful pictures about the types of sensation, and an overview of the purpose of sensory evaluation. Among many different answers, it also assesses the type and extent of sensory loss and provides direction for OT intervention and determines the need for desensitization. So it's very crucial. And then next we have evaluation of sensation and intervention for sensory dysfunction according to Pedretti. So we have the different types, including pain sensation and the procedures for that, temperature awareness, using thermal test tubes, testing for touch sensation, again, 2-point discrimination, static and moving, touch pressure and how to do that with the monofilaments, and proprioception as well. This also includes stereognosis, which is the use of both proprioceptive and touch info, and talks about the Dellon modification of Moberg pickup test. There's also localization of touch, and then an overview of the somatosensory system, so techniques such as desensitization, sensory re-education, which can be protective or discriminative. So the battery of tests you select will depend on whether the diagnosis is central nervous system or the peripheral nervous system. And then here's the assessment and intervention for perceptual dysfunction. So this is what perception is. It's the mechanism by which the brain interprets sensory information received from the environment. Some general principles for the OT assessment, general approaches for OT intervention, the remedial or adaptive, and then assessment and intervention for specific perceptual impairments. So these are the specific impairments. And then it talks about tactile perception disorders, dysfunction with right or left discrimination, visual spatial perception disorders, motor perception disorders, and behavioral aspects of perceptual dysfunction. And now we're moving on to concept map number 7. So starting over here, these are the procedures for goniometer measurements, and it's important to measure during evaluation to get a baseline for upper extremity and to measure the progress. Here are some contraindications for patients with pain, scar tissue, or edema. These are important to know. The disadvantages and advantages of these different scales for pain. There are precautions that you need to be aware of. And here's the testing procedure for recording range of motion. And it's important not to perform this when patient has had a recent fracture, healing, surgery. It's against their medical chart precautions, etc. Knowing what end fields are and active range of motion versus passive range of motion or active assistive. And OT can also work on lower extremity, not just PT. And then looking at torque and moment arm with some helpful pictures and the lever systems, which we learned our first semester. This is from Radomski chapter 20. This talks about how to maintain or prevent limitation in range of motion through edema and contractures, and our biomechanical approach to treatment for strengthening, stretching, increasing endurance. And that concludes our e-portfolio.